Good morning, ladies and gentlemen. There we go. How's everybody doing today? Excellent. Well, my name is Crystal Davis. I'm the Senior Project Support Specialist for our Goizueta Brain Health Institute, and I'm honored to welcome you to the 30th Brain Health Forum. This is a milestone event, and out of curiosity, how many of you or any of you have been to all 30 forums? We know life happens. Dr. Monica Parker has. Anyone else, any of the guests have been here almost, and we understand that life happens and maybe you've missed one or two, but overall, we are just delighted to have you. And thank you for those who've been coming for over 15 years.
So the theme for our program today is prevention, detection, and maintaining, right? You're going to hear all about that today. Before we get to that, though, a very important person, Dr. Alan Levy, who is the founder of our Goizueta Brain Health Institute, former chair of the Department of Neurology, but is responsible for not only founding the Goizueta Brain Health Institute, but the Goizueta Alzheimer's Disease Research Center. And because of the participation of so many people in research and because of his ability to get so many different researchers on the same page, Atlanta is destination research for brain health and Alzheimer's research. So at this time, I'd like to bring up Dr. Alan Levy to greet you, and following that, we'll have another greeting from another important person. Come on, Dr. Levy.
Thank you, Monica. Thank you, Crystal. Thank you, John. This is incredible. 30 Brain Health Fora. Amazing. So thank you, all those who are repeat attendees. Glad to have you here. Welcome our newbies. Today's really a special event. Of all 30 of them, we've been building up towards this one because it's about prevention and keeping well. This has been one of the most exciting times in my career because we've seen so many advances. We understand that much of dementia, cognitive impairment, might be preventable through lifestyle management. Doing things like we just did with John, getting out of breath every day for maybe 15 minutes is a great way to keep your brain healthy as well as your heart healthy, and you're going to hear about that. One of the things I'm most excited about is looking towards a future of prevention. Changing our lifestyle to be brain health protective is up to us. We can develop tools to help coach people. But we also know that's not enough. We know that the disease, like Alzheimer's disease and related conditions, start in the brain literally decades before people develop symptoms. That 20 to 30 year period when things are changing in the brain, for me as a physician, provide this huge opportunity, a window of opportunity for us to begin to think about identifying people at risk, helping make sure they are doing the lifestyle modification that can help them, and also thinking about a next generation of really targeted medicines that can get rid of the underlying changes of Alzheimer's disease. Little did I know a few years ago that we could say we can give people infusions that will get rid of all the amyloid plaques in their brain. Absolutely amazing. One of the key hallmarks of Alzheimer's disease. So we have things we can do now to slow down the course of the disease. All that rests on early detection. You're going to hear about that from our guest, Dr. John Showalter from Linus Health and his approach to prevention and early detection. You're going to hear today from Dr. Amy Rodriguez, who leads our Lifestyle Core and Cognitive Empowerment Program, talk about lifestyle risk factor modification. You're going to hear from Dr. Felicia Goldstein about how some people are super agers and can keep their brain healthy. And you're going to hear about radiomics and how imaging can help detect early changes as well. So you have a great morning ahead, learning about what you can do to keep your brain healthy. Thank you for your participation with us, not only coming today, but for those of you interested in research. This is a journey that we can only do together. We have an amazing team at Emory and colleagues around the country. We all work together, but ultimately our success depends 100% on your involvement and participation. So thank you very much and enjoy the rest of the day, and I'll turn it back over to Monica. Thanks.
There has been a lot of change, and we are happy to welcome via video, she did have a conflict today, Justice Leah Sears Ward, who is the interim president for Emory University. She'll tell you a little bit more about her story, but we're going to play her clip right now and her welcome and greeting to you.
Good afternoon, everyone. I'm Leah Ward-Sears, the interim president of Emory University and a proud alumna member of the Links Incorporated. It's a pleasure and an honor to welcome you to the 30th Annual Brain Health Forum held here at the historic Carter Center. This gathering is especially meaningful because it unites two distinguished institutions, the Links Incorporated and Emory University's Goizueta Institute for Brain Health, both of which are deeply dedicated to strengthening our communities through knowledge, compassion, and decisive action. For me, being here is not just a professional duty, it's a deeply personal one. My 96-year-old mother, also an alumna member of the Atlanta chapter of the Links Incorporated, is currently living with Alzheimer's disease. Watching her journey has shown me in the most intimate way both the heavy toll this disease takes on a family and the incredible power of love and science working together. We know that Alzheimer's and related dementias do not impact all communities equally. The statistics serve as a call to action. Black Americans, for instance, are twice as likely as white Americans to develop Alzheimer's or other dementias. Approximately 1 in 5 Black adults over 70 currently live with Alzheimer's. And despite this higher prevalence, Black patients are much less likely to get a prompt or a correct diagnosis. That is why access forms the foundation of our mission. Access to early screening, culturally competent care, and the clinical trials that shape the future of medicine. For too long, Black communities have been underrepresented in research. If we want to ensure that new breakthroughs and miracle drugs work for everybody, we must be at the table and in the laboratories. Changing this narrative is more than just a scientific need, it's a moral obligation. I am so proud that Emory is leading this work alongside the Links, whose legacy of service continues to inspire me every single day. Each of you here is a critical part of that legacy. Together we can move from awareness to action, from research to results, and from hope to healing. Thank you for your dedication to making brain health a community priority. I hope you all have a meaningful and inspiring forum.
So, we're going to get started with the meat of our program today. Our first presenter is Dr. John Showalter. He's the Chief Strategy Officer for Linus Health, which is a digital health company that enables the early detection of Alzheimer's and other dementias. These technologies are actually available here through Emory Healthcare. So with Dr. Showalter's presentation and more of what goes on this afternoon, you're going to learn you're going to learn more about how we are evaluating people for Alzheimer's and related dementias, what tools are being developed, and if you visited our tables out front, you're learning about the different studies we have for healthy people. All research isn't done to science. A lot of times it's just observation. So we're here to learn more about how to age more healthfully, what are the tools that can help us engage in that, and how you can further research. Dr. Showalter, will you come on up?
First, I'd like to thank you all for coming and for you guys hosting me. I think this is an incredibly important topic. So yes, in my day job, I run strategy and product for a digital health company that's mission is to make brain health available to everybody and to provide the technologies that allow it to be democratized. But really, I'm here as a physician. So I practiced for 10 years in Jackson, Mississippi, at the University of Mississippi. I currently live in Danville, Pennsylvania, where they have nice laws, like all biomarkers must be paid by your insurance. So if you've heard about the blood-based biomarkers for Alzheimer's, where I practice, they are required to be covered, so all insurance covers. So if you have something that you'd like to advocate for in Georgia, that's a thing that the government can do, is say your insurance must pay for these things. So it's really nice to tell my patients that, yes, I can use the blood test for Alzheimer's disease, and it is 100% covered by their insurance, nothing out of pocket. I would definitely, on the prevention side or the treatment side, encourage you guys to get that regulation. It's a nice one to have. We do, oh, how do I advance the slides?
Slide remote or prompt me.
Oh, okay, perfect. I'm good at prompting. So I'm not going to spend a lot of time on this slide because Dr. Rodriguez is going to talk all about this research. But what's really important is we now have multiple randomized clinical trials that say the same things. Lifestyle reduces your risk of dementia, slows down the progression of dementia, and in about a third of people, you can actually have improvement in your cognition with lifestyle. So without medication, without any other treatment, just making lifestyle choices can reduce your risk of dementia by up to 50%. And if you are in the earliest mild cognitive stages, a third of people can actually have improvement. And the center study shows that with a more intense lifestyle change, you can actually change it from 70% of people progress to 30% of people progress. So lifestyle is huge. No one really likes to hear exercise, eat better, there's barriers, and Dr. Rodriguez is going to dig into that, but it really matters. And it really matters to individuals. So I'm now practicing in Danville, Pennsylvania, and you can advance 2 slides. All of the pictures you see are my patients. They have volunteered to be used for educational purposes, have signed all their consents. We like consents with research. So please sign your consents, please sign your media consents, because they all signed theirs. Set up a clinic with my wife. So I have my day job, and my wife and I, Tuesday evenings, Thursday evenings, and Saturdays, see patients in our dementia prevention lifestyle clinic because people just were not getting this care. We were kind of into it until my mother was our first patient. My mother was supposed to be the person that didn't get mad if her billing went wrong, and I didn't know what I was doing. However, she did the digital cognitive assessment in my clinic and turned out to actually have MCI, which is the earliest stage of cognitive impairment. I called my dad. I'm like, what's up? He's like, oh, yeah, this happened and this happened, this happened. I'm like, you know what I do for a living, right? Tell me these things. So she was just not supposed to be my patient. But I was like, okay, so Mom, do you want to end up like my grandmother? Because I know you don't. And got super intense lifestyle. So she's lost 75 pounds. She's on a GLP-1 for her diabetes now, because it has the strongest evidence for dementia prevention and weight loss. If you've had a heart attack or a stroke, you might qualify for a GLP-1 for secondary heart attack and stroke prevention. Those trials have shown that it reduces the chance of a second stroke or second heart attack by over 26%. So if you've had a heart attack or a stroke, you should talk to your doctor about whether or not secondary prevention with medication is a good choice, particularly with what we know about how much vascular plays into the African American dementia. So we are seeing in our in our community activities that about 2/3 of individuals are amyloid negative, so they don't have Alzheimer's disease but do have cognitive impairment. And really being driven by vascular when we are in a community like this. So if we were to do a screening with the digital technology and blood-based biomarkers, the vast majority of people that showed that they had a problem would actually not have Alzheimer's disease. They would have something else, most likely vascular disease. So something wrong with the blood vessels in the brain. I have personally had 4 patients that had strokes that didn't know they had strokes, that their presentation for stroke was cognitive impairment, and they were silent, or they didn't have face droop, they didn't have, so the vascular piece is a very serious component to the related dementia part of Alzheimer's disease and related dementia. So blood pressure control, diabetes control, weight loss. Anyway, back to my mom. So she showed up, she had early signs. I'm really excited because she's in that third that got better. So she started piano lessons. She lost 75 pounds. She wasn't sleeping very well because she has back problems. We got her one of those fancy beds that sits up. And now she sleeps through the night. The only problem with that has been one problem where she woke up in the middle of the night kind of folded in half with my father screaming his button no longer worked because he had her controller. So aside from that, the bed's been really good. She actually said it's the best thing that's happened in like the last 10 years, which is unfortunate because I have grandchildren in there. But point being, she's in that 30% that got better. Her testing got better. She made massive lifestyle changes. You know, losing 75 pounds doesn't come easy, right? So way better diet, way more exercise, the right medications, and something super challenging like picking up an instrument. But she is now no longer has the symptoms of early dementia. So she watches my kids when we do this clinic because she's like, this is what you should be doing with your life. Go treat all these people. So what we're going to do is run through a couple more of my patients to give you guys a very clear idea that this is not a hopeless condition or an untreatable disease anymore. And it is, the main treatment is all stuff you can start doing when you leave here, and you started doing it with John. So thank you, John, because that exercise and movement is huge. So next slide, please. So if you don't know, if you are one of the 20% of care partners in here, your risk for developing dementia is 10 times higher than someone who is not a care partner. So if you are a care partner, please pay attention to Dr. Rodriguez's talk very closely, because you need to start all of this today. And also, if you are stressed, your loved one is much more likely to go to the hospital or the ER. And if you are stressed out as a care partner, it has been associated with up to 18 months of lost independence. So they will not be able to stay at home for 18 months less if you are stressed out. So your stress management is huge as a care partner. So next slide. This is Tammy. Tammy's mom has Alzheimer's disease. No one definitively told Tammy and her dad that her mother had Alzheimer's disease. It was, however, in her chart. I knew it when they came to me. I wasn't sure why they were coming to me because it was diagnosed. And I'm not saying they weren't told. I have been doing this long enough that when you deliver a diagnosis that no one wants to hear, they sometimes just don't hear it. You have to say it more than once. You have to support them. You have to guide them through it. You can't just like drop a bomb and be like, hey, were you listening? So I'm not putting shade on their doctor. They had one visit where it was, but I knew it. They didn't know it. So we were able to do, again, with the technology and the digital cognitive assessments, I was able to do testing in my office, say it's absolutely here, show them the results right there, walk them through the results, start medication for her mom, and bring them back and retest and say, hey, this stuff that we thought was going to get better actually did get better. Like this is, you know, this medication rewinds the clock a little bit, but it's still a progressive disease. But we're able to actually show them that progress. And when they come with a concern or a symptom, we can do testing in my office to test what they're worried about and say, actually, no, her memory is just like it was 6 months ago, you know, or her thinking and planning is just like it was 6 months ago. Let's talk through this. Or actually, yes, it's worse. This is part of the progression. You know, what is your plan? You know, when are you going to be able to have more resources at home? When can we bring, you know, something to bear to help you and get them that support that they need? So the certainty and the ability to do something in primary care that it gives a result right away is huge. It does not replace the full neurocognitive testing. It does not replace the neuropsychologists. There are absolutely people that need that detail, and often both are done. I can track in my clinic, and a full neuropsychological evaluation is done as well. But it allows us to act and respond and provide that certainty in a way that reduces her stress, lets her know that what they're seeing And the number one comment that I get from my patients is, it's so good to know I'm not imagining it. Even people with Alzheimer's disease or dementia, their family saying, well, I'm glad to know for sure that they actually are getting worse, that it's not just me getting tired, that it's not just me getting burnt out, that this is actually getting harder, and having those discussions. So we're working really hard on her stress and with her. So a lot of my patients are my patients' children. That wasn't the original plan, but no one was taking care of them either. So we do a lot of care partner education, care partner stress management, and make sure they're also taking care of their chronic diseases and tell them to take their blood pressure meds. So next slide. This guy I'm super proud of. So he is a 6'4" diesel mechanic that walks into my office, and I have to go like this. He is caring for his dad. They're in a very stressful farm situation where if anyone here has cognitive impairment, please talk to somebody about making sure your finances are okay. They're having farm trouble because he has made so many donations to philanthropic causes that they almost have no money left. They now have the bank no longer cashing his checks, which is good, but he's super stressed. He's also so stressed he's having relationship problems, and we saw his son, him, and his dad, who's having the problems, in the clinic, and the grandson said, "Hey, Dad, you're forgetting stuff. You're not doing as well on those tractors as you used to. I'm really concerned about you." And he agreed to come in and get tested. So he's in his mid-50s. He tested. His testing showed that he absolutely is having attention deficits, most likely due to his complete burnout. When we put him on you can measure stress scales. So we did the stress scale for his, and it was like as high as you can get. And we sat down with him and said, you can't do this to yourself. Like you are the statistic that shows why care partners get dementia. Like you can't live stressed out like this for years on end. He now has a counselor, and he is now doing much better. And he has lost like 20 pounds because he's less stressed out. And I convinced a 6'5" diesel mechanic in the middle of nowhere, Pennsylvania, to go to a counselor. So men, don't be stressed out. Go to counselors. It's good for you. And it can be your pastor. I mean, it doesn't have to be like a psychiatrist, but get help. Don't be stressed. It is incredible seeing him come back over the course of a year from being completely stressed out to really managing his stress. Oh, thank you. To really managing his stress. And no one was talking to him about his stress. No one was saying, hey, your risk of dementia is elevated because of how stressed out you are caring for your dad. If you're a care partner, dementia prevention starts with managing your own stress. And then it starts with doing all of the lifestyle stuff that you need to do despite your stress. Because it's not a happy place. You're not going to be not stressed. We're not going to get you to a point where you love being a care partner. But you still need to get your exercise in. You still need to eat well. And if you're not exercising and eating fast food and not taking your medications, you're putting your risk of dementia up like 50%. And then quality of life. So this is probably my most exciting one, and my wow, I'm not always a good doctor one. So I started doing cognitive prevention. I was a cognitive care dementia prevention, and I had a speech language pathologist that specialized at knock on my door and say, "You haven't referred anyone to me." And I said, "Why would I refer them to you?" And she said, "Because I do this whole laundry list of things. I do caregiver education. I do communication between the spouses when someone has cognitive impairment. I look at what is wrong with their cognition and how you communicate with that person. I do a whole lot of training on, given this deficit in your brain, this is how you could make your life easier." All of my patients now go to speech language pathology. All of them. Because I was totally wrong, and I practiced for years, decades, and never referred someone with cognitive impairment to speech language pathology. Horrible idea. They are fantastic. They are amazing, and they do so much. I have had couples come back where the care partner is crying in my office because their stress is so much lower because of something that happened at the care partner. But dementia, but as Dr. Levine said, it starts early. So this is my 55-year-old patient who's a nurse who came to my office and said, I have to quit nursing. I am forgetting names. It's called a Pyxis machine. When I go to the Pyxis machine to get medication, I'm struggling in a way that makes me think I'm going to make a mistake. I think I need to quit nursing, and I think I have dementia. And we did the evaluation, we did the testing, and we started digital cognitive rehab. So there's an app that works on how fast your brain works. It's been shown through clinical trials to increase the chemicals in your brain. And we also sent her to speech language pathology. She went from wanting to quit nursing to getting promoted as a unit educator because she leaned into the lifestyle stuff and absolutely normalized. We actually studied how fast her brain went. She increased her brain speed by more than 50%. So this is absolutely a condition that can be treated, that dementia can be prevented. So if you walk away with nothing else, dementia is preventable if you start early. MCI is treatable with lifestyle. And although dementia is a chronic progressive disease, care partners need treatment, and it can be slowed down. So I think that brings us to our Q&A.
Okay, lots of blood test questions.
Okay. Okay, what is the blood test? So what is the blood test to check for vascular impairment? So there's no blood test to check for vascular impairment. That's done with an imaging of the head, an MRI, to look at the structure of the blood vessels and whether or not there's any tissue that has essentially died from not getting enough oxygen.
They have types
Okay.
and the cost.
What must you do to get the blood-based markers covered by insurance? So in Pennsylvania, that was legislated. So the Senate and Congress and governor made it a law. But you also can do it through regulations with the whatever the HHS is of Georgia.
Department of Public Health?
Probably. Is there a blood test to detect plaque in the brain? Yes, they are all blood-based amyloid tests that exists. I'm not going to name any brands, but they're all available by the major labs. And its cost is generally a couple $100 if you have to pay out of pocket. Yeah. Is the GLP-1 better for MCI than losing weight without them? So that's a hotly debated topic. We don't know whether it is the weight loss or the GLP-1 something else that it's doing entirely on its own. What we do know is people are most successful with losing weight with the GLP-1, so that's not sorted out yet at all. First and foremost would be weight loss because it's also all the vascular stuff that we know it matters. So there is decidedly research that shows GLP-1s have a protective effect. The randomized clinical trial in later stage disease showed that it did not reduce functional decline, but it did reduce plaque accumulation of both amyloid and tau. So the thought process is it needs to be used early as preventative. It is not a treatment. The name of the brain speed app, this one I will give you because there's only one. There's only one that's been through clinical trials. It's called Brain HQ. And you can download it and do free trials on it on Android, Apple, or your computer. Brain HQ. It's by Posit Science. I encourage everyone. I have it on my phone. So, okay, the app. Yes, we answered that one.
Blood
Yes, you can. So the blood test does not have any restriction on who can order it. So your primary care physician can order it. What I will say is it is indicated to be ordered in people that have had cognitive testing. So if you have not had cognitive testing, the blood test alone is potentially very misleading. There are other conditions that make it positive. So if you just go and get the blood test, you can be worried about stuff that you shouldn't be worried about. If you just use it for Alzheimer's disease, that has a relatively high false positive rate for Alzheimer's disease without brain dysfunction signs. So I do not think anyone should just get the blood test. But if you can get the cognitive testing and the blood test, I'm a fan.
Okay, so talk about the p-taus. This is kind of like those blood tests.
Yes. Okay, so I'm going to preface that. So this question is, can you talk about the p-tau levels in African Americans and the association with dementia and Alzheimer's disease? So I'm going to give you my opinion from seeing the data that we have from the studies that we have done. This is my opinion. This is not scientific fact. It appears that we have grossly underestimated the amount of vascular disease in the African American population, and that those that have amyloid plaques likely are positive on the blood tests, but so many are negative on the blood test because when we actually do look at the PET scans or the CS, it is not primarily Alzheimer's disease, it is primarily vascular disease. And again, we are seeing time and time again when we do community events that the vast majority of individuals in African American populations are amyloid negative and vascularly positive. So that's my experience, not proven yet. Those studies are underway though. So how do you find a good medical provider that is proactive with MCI and current on medical treatments? So this is hard. My biggest recommendation is that you ask. I think you just have to say, what is your experience with treating mild cognitive impairment, and how familiar are you with the most treatments? Now, what I'll say is neither one of these things is particularly complicated. A primary care doc can go and watch the 13 hours of free education from the American Academy of Family Practice and really be able to do this. This is not complex therapy. This is stuff we do every day. This is lifestyle medicine that we do every day. We just need that bit of education to understand that MCI is a lifestyle treatment for 95% of people. All right, and the last question. Okay, so if dementia is degenerating in the brain, how can it be preventable? So this is partially a definition of preventable. So in clinical speak, prevention means we are able to stop it from happening or stop it from getting worse. So we do actually know, and Dr. Rodriguez is going to talk about this, up to 50% is preventable. You are able to stop the degradation of the brain. We don't entirely understand why. We don't completely understand the original things that cause the cascade. But we know that if you start in your 30s and your 40s, you can prevent it. Just like if you control diabetes, you can prevent the kidney damage that leads to needing to be on dialysis. But that has to start decades earlier. So the prevention is really early. And we're trying to talk to more people about really worrying about your lifestyle in your 30s and 40s in order to prevent it. But where we consider prevention in dementia often is at this MCI level, the first level where we can detect that your brain is having problems. That's not dementia. So you are able to live independently. Some of the stuff you used to be able to do is really hard or you can't do it, but you can still go about your day. And what we want to do is make you able to go about your day for your entire life, and we consider that preventing dementia.
Last call. Any questions? I think we have 1 minute. My time. Keep it. One more. Any more questions? Did you write it down?
So, I love this. I'm a breast cancer survivor, and when I went to some of my classes, the things they were telling me at 65 years old, I should have been learning in 3rd grade.
So I 100% agree. I have 5 kids, and they're tired of their dementia prevention education. And the oldest one's 23, and they're all tired of it, right? So I 100% agree. Like, we have got to, the company I had, we went to a high schooler HOSA event and built a brain health education website for them that was super gamified, and they found out like they were dolphins or wolves or something that said like, here is your personality type and here's how you protect your brain. Because I 100% agree with you. We have got to shift this upstream in order to have the kind of impact that we've had on diabetes and heart disease and cancer. Because you have to start getting all of the nutrition and exercise way earlier. So I am always up for trying to help someone out with that.
The one thing I'd add is I'm really feeling good about the fact you're saying GLP-1s help to stop this. You got so many African Americans, particularly our women, who are on these GLP-1s. So we're doing something right in that area that'll have an effect on this. And I think that's awesome because they may not listen, but they're on those GLP-1s.
So if you visited any of our vendors outside, some of the prevention that we're talking about has to do with nutrition. We have preventive exercises or observational studies that you've learned about in front. And I'm going to encourage you, what can we do? What can we learn? If you're over the age of 65 or 65 going up, make sure you take advantage of your annual wellness visit, where a lot of the things that we're screening for are done during that visit. Every provider who's a primary care provider, internal medicine, or family physician should, as part of their annual wellness visit, do a memory screen, a depression screen, an anxiety screen, and talk about a lot of the things that Dr. Showalter talked about. So I'm going to encourage you to go back to whoever your primary care provider is and ask about these things. It's the basics. If you learned anything, it's the basics that we need to be aware of, not the exotic blood tests, the MRIs, and all that other stuff. That comes, but you got to take care of the basics first.
Yeah, and so the last question here is, how does alcohol consumption affect Alzheimer's disease? So we know that in excess it's really bad. I will say that I drink a lot less since I've been doing dementia prevention, if that's any indication. But I think I work with a cognitive neurologist from Harvard who is a Spaniard. And so he has strong feelings on alcohol and socialness. So I think his perspective is best, in moderation, and particularly if it is being done socially, because being social is so important for your brain. It's offset, and don't stress about it. But also, if you can't walk home, that's not good for your brain.
Thank you. Did you learn something? We're going to do better, right? Okay, the next person who's going to speak to us today is Dr. Amy Rodriguez. She leads our Lifestyle and Empowerment Core for our Alzheimer's Disease Research Center. And she came here, I guess this is our 30th presentation, maybe around the 10th or the 15th, to talk about exercise, because her research has to do with exercise. So Dr. Amy Rodriguez, would you come up here, please? She's going to talk to us about lifestyle.
Well, good morning. It's a pleasure to be here with you. I'm going to talk about lifestyle changes in dementia prevention. And I'm really excited to talk to you about this because there's a lot of new scientific evidence that gives us reason for hope, and we've heard about that a little bit so far today. But I'm going to talk with you about the U.S. Pointer study, which is one of the largest dementia prevention studies that has happened to date in the U.S. I'll talk to you about the lifestyle risk factors for preventing and delaying dementia from the Lancet Commission report. And then I'm just going to briefly talk to you about a new lifestyle and empowerment core that we have at the ADRC. So let's jump in. So like I said, the U.S. Pointer study is actually the largest dementia prevention study in the U.S., which is really exciting that we're doing this work here. It is a randomized clinical trial that was across 5 sites here. They asked a pretty simple question. Can lifestyle interventions protect or improve cognitive function in older adults at risk for dementia? So what did this mean? So who was eligible to participate? People had to be 60 to 79 years old. They had to have no cognitive symptoms, so not yet experiencing any issues with thinking or memory. They had to have an inactive lifestyle, which meant that they had to have 60 minutes or less of physical activity per week, and then what would be considered a poor or suboptimal diet according to a Mind Diet screener. And we're going to talk about the Mind Diet a little bit later. So does this represent the US population? It actually does, because we know that about 35% of older adults don't meet physical activity guidelines, about 80% don't meet dietary guidelines, and about 55% have heart or metabolic issues. So this is actually pretty representative of the US population. Okay, so what did they do in the Pointer study? So the Pointer study is what we call a multi-domain lifestyle intervention. That means they're addressing more than one risk factor at a time. So for the Pointer study, they intervened on physical activity. So they were providing support for people to meet the guidelines for physical activity from the American Sports Medicine. They were doing brain exercises, so they were using Brain HQ, which we've already talked about today, and they were encouraged to use Brain HQ for up to 30 minutes, 3 times a week. They also were encouraged to engage socially, and they were given nutrition education on the Mind Diet, and then finally there was health monitoring for medical risk factors related to their heart and metabolics. So what the study did was it actually compared 2 groups. It compared a group of people who got a structured intervention and a group of people who got a self-guided intervention. And so everybody practiced the same healthy habits. It was just a matter of the amount of support that they received. So the structured group, they had a coach and a navigator and an intervention specialist that helped them along in the 2 years of the study. They also had more meetings. So compared to the self-guided group, they had 38 meetings. And then they also had personalized plans, okay? So it was really very structured, very supportive as they went through the 2-year intervention. The self-guided group had access to information, but it wasn't as personalized, and they had fewer meetings. So this idea of support is something that I want you to keep in mind. So the measure of success for the Pointer study was thinking and memory ability, and they did this through a number of tests that they administered before the intervention began, and then every 6 months for the 2 years. Okay, so who was part of this study? There were over 2,000 people enrolled in the study, and they were equally split between the structured group and the self-guided group. And now this was a randomized control trial, which means they didn't get to decide which group they were in. That was assigned to them. And when we look at the 2 groups, they're similar on demographics. And so this is really important because that allows us to make a fair comparison between the 2 groups. So participants were about 68 years old, and about 2/3 of them were women. About 30% had no college education, and about 30% were from underrepresented groups. And this is really important because we want the research that we do to generalize to the population. And actually, this group was a little bit more diverse than some of the other prevention studies. And so that helps the findings be more relevant to a broad population and to those who are at risk, higher risk for Alzheimer's disease. Okay, so let's talk about the study findings. One of the things that we want to know when we participate in an intervention study or when we hear about it is, did people do what they were supposed to do? Did they follow the instructions? And so for both groups, attendance at team meetings was above 90%. So that is one indicator that they were doing what they were supposed to do. They were following along with the program. There are other indicators, and there's some additional work going on with the data analysis that would tell us how they adhered to the prevention intervention. But let's take a look at what they found in terms of the thinking and memory ability. So if we look at the graph on the right, what this shows is their results over the 2 years, over time. And so we've got 2 lines there. The top line is the structured group, and the bottom line is the self-guided group. And what we see is that both groups actually improved, okay? So they improved their thinking and memory ability over those 2 years. But what's important here is that the structured group improved even more. The difference was significant between those 2 groups. So again, this tells us how important it is to have that structure and that support when you're making lifestyle changes. A couple of other things that they looked at was whether the results depended on or were related to people's backgrounds or other risk factors that they might have. And what they found was people were able to benefit regardless of age, sex, and other risk factors, which includes genetic risk factors. So that's really good news as well. And then another thing that they found was actually people who had lower thinking and memory ability at baseline or before the intervention started, they actually improved more, possibly because they had more room to make improvements. So thinking about, what we've learned from the Pointer study and what we might take away, we learned that lifestyle changes can improve thinking and memory. So not only protect it, but they improved a little bit over time as well. We know that people with different backgrounds and risk levels can benefit from these interventions. And we know that structure and support really do make a difference. The ones that had a lot of support and had a coach and more meetings were able to make really meaningful changes. But what we also know is that more research is needed. So this report out is really just about the 2 years of the intervention. But what about the longer term impact? How do these changes affect people over time? That's something that we still need to know more about. And actually the US Pointer study has an alumni group of people who participated who agreed to be followed for an additional 4 years. And so we're really going to be able to learn a lot about the durability of those benefits and whether they're sticking with those lifestyle changes. And we also need to understand translation of this type of intervention in other settings. So they were given in, like I said, 5 communities across the US, and they had community support, but it's important to look at different communities that maybe have different levels of resources to understand how these interventions might be carried out in those contexts. So very promising results, and I think it's something to be excited and feel hopeful about, and a stepping stone for the next few years of intervention research. So now I'm going to talk to you, switching gears a little bit, about just how powerful these changes, these lifestyle changes can be. So in 2024, the Lancet Commission on Dementia Intervention, Prevention, and Care, they gathered evidence from research studies around the world that were looking at dementia prevention. And what they found is that up to 45% of dementia cases can be prevented or delayed by addressing 14 modifiable risk factors. Right? That's right. So there are 14 factors that you have control over that can help prevent or delay dementia. And what this graph or this figure shows on the right is that these lifestyle factors are identified across the lifespan, okay, from early life all the way through late life. That means it's never too early to start and it's never too late to start. And we've already heard about that today, right, from one of our audience members. Okay, so let's take a look at these risk factors. The first set of risk factors we can talk about and kind of group as staying active, okay? So physical inactivity, low education and low cognitive stimulation, and social isolation are dementia risk factors. So it's incredibly important to stay physically, cognitively, and socially active. Now, what do we mean by that? So physical activity, there are standard recommendations of getting at least 150 minutes of exercise per week, and ideally doing that over 5 days per week. There's also recommendations for strength training at least 2 days a week. And just overall spending less time sitting. We've really begun to understand how, how detrimental sitting is when you sit for long periods of time. So getting up every now and then and just moving your body can be really helpful. So walking is one of the best ways that you can do that, but also chair-based exercises. How fun was that, right? So, sitting in your chair and just moving your body can be a really powerful way to increase your activity. And then remaining cognitively active. So we know the brain loves a challenge, and we can build resilience through keeping our brain challenged. So lifelong learning, right? So we heard Dr. Showalter talk about how his mom picked up a musical instrument. That's wonderful. That's a wonderful way to learn. Learning a new language is another way. Learning new skills. These are great ways to keep your brain active. Creative pursuits are wonderful as well. Using different parts of your brain is really important. And then things like puzzles and games and reading. And we talked about Brain HQ, right, for brain training. So that's really important. And then finally, staying socially active. Especially in late life, social isolation is a really big risk factor. And so, remaining connected with your family and your friends and even your pets, this is a wonderful way to have meaning and purpose in life, but also social activity helps the different parts of your brain, the stronger connections between brain regions. So this is a really important aspect as well. So be part of your community, volunteer if you can, and just remember that you need people, and people need you too. So staying active. Let's move on to the next one. So there's a really strong connection between your heart and your brain. So protecting your heart, in a sense, means protecting your brain. The risk factors kind of under this umbrella are diabetes, high blood pressure, and high LDL cholesterol. So, and so are obesity. That's another risk factor. So we want to make sure we're monitoring our numbers in that respect. And that's a little bit different for everyone, so you want to work with your doctor on that. Exercise and diet can be helpful, in taking medications as prescribed. And then a couple of other risk factors are excessive alcohol. We've already talked about that, limiting to no more than 2 drinks per day, and not smoking. Also supporting your mood and senses. The way that we feel and the way that we experience the world can impact our brain. So if you're experiencing depression or stress, talking with a healthcare provider or your pastor or somebody and following the treatment plan that's recommended will be really important for reducing your risk. Deep breathing and mindfulness and other things that can improve well-being are also great ways to reduce your risk. Maintaining vision and hearing. So vision and hearing loss can make it harder for the brain to process information and can reduce your interaction with other people as well. So it's important to get regular checkups. Sometimes we don't even realize we're not hearing well, or we're not seeing things quite the way that we could. So regular checkups, using your glasses or contacts and your hearing aids as prescribed is really important. And then being smart about safety, so preventing head injuries and minimizing your exposure to air pollution. These are really important ways to reduce your risk. Preventing head injuries, you can do that by wearing your seatbelt when you're driving, wearing your helmet if you're playing sports or riding bikes, and fall-proofing your home. And then to minimize your exposure to air pollution, just limiting time outdoors if there's high levels of pollution, and using purification and ventilation. Now, we've already talked a little bit about sleep and activity as well. They did not make it into the Lancet report, but there is good scientific evidence that diet and sleep are very important for brain health. And so the recommendation is to follow the MIND diet. Who here is familiar with the MIND diet? Okay. Who here is familiar with the Mediterranean diet? Okay, great. More people with the Mediterranean diet, good. So the MIND diet is actually a combination between the Mediterranean diet and what's called the DASH diet for hypertension. So you already know a little bit about it if you know about the Mediterranean diet. So the MIND diet is recommended because it is known to reduce inflammation and other risk factors that we've already talked about for dementia. So adding leafy greens, berries, beans, nuts, whole grains, healthy fat and proteins. And then there are a few things that we have to limit, and that's added sugar, saturated fat, red meat, and ultra-processed foods. And then finally, supporting healthy sleep. So we all know that we need to get more sleep, yet that's one of the things that sometimes is really hard to do. What we want to do is aim for at least 7 hours of sleep a night. And what can help with that is having a consistent sleep routine. What does that mean? That means going to bed every morning or at night around the same time, and waking up each morning around the same time. It can also really help to have a wind down routine before you go to bed, just to prepare yourself for that. And then good sleep hygiene. What does that mean? That means being mindful of the sleep environment. So the temperature and the lighting can really prepare your body for sleep, but also avoiding things like caffeine and heavy meals and screens before bed. So don't be on your phone, not watching TV about an hour before bed. And then finally, I'm just going to wrap up with a couple of points to remember on these lifestyle changes. So small, consistent habits can make a big difference. You don't have to change everything at once, and you don't have to be perfect. You can improve your brain health just through small changes. One change can lead to many benefits. So we know that if we change exercise, we can reduce our weight and our blood pressure. That can have a positive effect on sleep, which can give us more energy for cognitive and social activities. So it's a ripple effect. And then finally, you don't have to make changes alone. And we know that from the Pointer study that you shouldn't try to do this alone, that you should seek support. So talk to your healthcare provider, find a brain health buddy, and get the support you need to make these changes. And remember to start as soon as you can, and it's never too late to do that. That's what we see as well. And then finally, just a word on our Lifestyle and Empowerment Core. This is a new core that we have at the ADRC. Very excited about it. It's the only ADRC in the nation that has a core specifically looking at lifestyle. So we're looking at measurement of lifestyle behaviors through wearable technology, and also support for lifestyle intervention research and access to education. And a lot of this is through the Charlie and Harriet Schaffer Cognitive Empowerment Program. We have a lot of resources in terms of in-person and digital interventions, as well as weekly online sessions that we've already heard about today, and printed materials as well. So we're really excited about the ways that we're increasing the efforts in science and education. And if you want to swing by our table, we are at the drink bar outside. So I just want to leave you then in closing and say that I want you to remember from this presentation that brain health is not out of your control. There are things that you can do starting today to improve your brain health and to reduce your dementia risk. And I hope that you'll share that message with someone else too. Thank you.
Okay, Dr. Greeney. If you've got some questions, please write them down and hand them to the hostesses, and if they're duplicate questions, they won't get read again. We'll just do it once, okay? Dr.
So first question, I enjoy watching TV, game shows like Jeopardy, The Chase, puzzles, etc. Is this a waste of time? Do I need to limit this to 2 hours of watching TV? There are a couple things about watching TV. I mean, these are great shows, don't get me wrong. Jeopardy's got your brain going and all of that. But typically when we're watching TV, there's two things that might kind of lessen this as a positive behavior. We're normally sitting. and we're not necessarily interacting with someone else. So is it bad to watch TV? I think, like I said, some of these examples are good, but just think about the amount of time maybe that you're being sedentary. Take breaks, stand up, and remember that interacting with other people is probably, a positive thing to think about as well. Obesity is a problem. Who can help for better weight loss? And so this is something that you can talk to your healthcare provider about. There are supportive strategies, which are behavioral strategies. You can talk to a dietitian who can do a metabolic assessment with you and get you on a healthy eating plan. And one of the things that we talk about when it comes to diet is making small changes and letting those small changes build on each other. So, swapping out your vegetable oil with olive oil, right? Making sure you have some color on your plate. Those are things that can make a difference. In regard to the risk factor about preventing head injuries, can you speak on the research about the impact of concussions on older adults? Yes, so we know that concussion, which falls under brain injury, is a really important factor. And even small, what we would consider mild brain injuries like concussion, can have an impact over time, especially if it happens multiple times. And so what can happen in the brain is that there's buildup of proteins that can increase your risk. And so that is kind of the driver of that risk factor, and why it's so important to reduce that risk through, like I said, wearing helmets and all of that, but also fall-proofing your home. Falling is a very high-risk thing for older adults, and that can happen in the home when there's trip hazards or inadequate lighting, or if you've got a lot of things that you always have to reach up for. Putting things in reach can be really helpful. Okay, next. Is it harmful to play the TV while I sleep? Okay.
These are all together.
Altogether. Yes. I'm okay. Yeah, that's the answer. Some people feel like it kind of can lull them to sleep, but also there is background distraction. And remember that limiting screen time, which is TV and your phone, can help get better sleep. And so it is better to not have your TV on. Okay. I was told getting, what is the realm of sleep and why is it important?
I guess it's REM
Okay,
sleep.
yeah, REM sleep. Okay, so one of the things I didn't talk about is what happens when we sleep. Okay, when we sleep, there's so many wonderful things that are happening in our brain. One of them is that our brain is clearing toxins, right? So it is clearing those, things that can be harmful for our brain and build up proteins. So that's really important. The other things that happen in sleep are that helps us regulate our emotions. Have you ever had a really bad night's sleep and the next day you're a little grouchy or maybe just a little sensitive and all of that? So that getting sleep helps us with emotional regulation. It also restores our energy. So those are all really important reasons, but yes, clearing toxins is really important. Does the structure in general contribute to greater thinking ability and better memory? Okay, so one of the things that we are trying to understand, I think in the Pointer study is trying to understand, but also we're trying to understand in general, is what is it about the structure? In our program at Emory, which is a multi-domain lifestyle program for people with MCI, they say that the social component and being with other people and having that support is among the most powerful things. And so the structure might not just be about getting, your personalized plan and all of that, but about the community around you who has a similar goal, who is helping you move along. So does the structure itself change your thinking and memory? No, but it might help you engage in those behaviors more often, more regularly, and it might give you that community around you that's really important for making change. Okay, listening to music with a headset at night while you sleep, is it okay? Tricky. There are some things, so I feel like this is part of some people's wind down, right? You know, you listen to music and you get your body prepared. You know, if it's not impeding your sleep, you know, it may be okay. There are actually studies now with earbuds that people wear at night that are introducing auditory stimulation that are helping them get into deeper sleep. However, that's a little bit different than listening to music. I think if it helps you fall asleep, that's positive. Not sure if that's helping you get into REM sleep. In spite of regular schedule, no electronics, no caffeine, how does one sleep more? I can't sleep more than 6 hours. Yeah, so those are just some supportive strategies, but it is true that some people still have difficulty sleeping for the right amount of time. As we age, you know, it just gets a little bit more difficult to, you know, to get that target amount of sleep. And if you're doing all the right things, like I talked about, all those supportive strategies, it may be helpful for you to talk to your doctor about ways that you can maybe improve your sleep.
I'm going to give you these. I'm going to ask one.
Okay. There's one question here that says, is any stage of dementia that is too late or terminal? So it's really important to appreciate that dementia, from whatever cause, is a neurodegenerative disease and it progresses. And there's a point at which there's no return. So when somebody's placed in hospice care for any other chronic illness, we know that there's not really much more that medical science, medicines, or anything is going to do. So that would be a terminal stage. The same thing happens with neurodegenerative disorders. They progress to the point where there isn't a recovery process that's possible. And when people are in a terminal stage of any chronic illness, they are usually put into a palliative care or a hospice program. And hospice care and palliative care are appropriate for people with neurodegenerative disorders, including dementia.
This is an interesting one. What's the impact of doom scrolling?
What's doom scrolling?
Do you know what doom scrolling is? Getting on your phone and then just scrolling and scrolling, whether that's through Facebook or TikTok, whatever. Okay, few things that come to mind about that. Not recommended. And so what is that doing? One of the things I think that they're finding out about people who are engaging, especially with social media and things that have short attention, is that it's kind of reducing your attentional abilities. You're paying attention in small bits of time, and that's teaching your brain to do that. So who's heard of the term neuroplasticity? Probably a lot of you. Yeah, that means that the experience that we give our brain trains our brain in a certain way. And if we're doom scrolling and we're looking at something and we're not paying attention, it's just very fast, that can impact our brain. The other thing is that you're getting a lot of screen, access or blue light from the screen. So if you're doing that at night, it would be extra bad. And you're not engaging with the world around you. And I think that's the bigger thing. How many people have gone to restaurants or out to a park or something and you see everybody just staring at their phone? They're not talking to each other. They're just sitting there looking at their phone. So I think the doom scrolling kind of plays into that as well. Okay. Okay, how do we decrease air pollution in our environment? So there are air purification systems that can be used, ventilation systems for indoors. You think about your indoor spaces as your home, but also your car and other places. So I think the best way to do that is to use those purification and ventilation systems. But I think, in terms of the minimizing exposure, like many of these things, there needs to be enough evidence and enough push behind to change things at a societal level and to push for regulations and other things that are going to reduce our risk around these risk factors. Okay. Why do the HHS recommendations contrast the MIND diet? The MIND diet is based on scientific evidence. So what? Okay, so yeah, so that is what we that's what we want to follow. We want to follow the science. We want to follow the things that tell us that these approaches really work and that they're impactful. And I think that the more research we do, hopefully that message can come out. But it does matter that people are looking at the science.
So, with that, we're going to move into our break time. There are a couple of questions here I'll get to, but please give Dr. Rodriguez another hand. I'm going to answer a couple of questions that we didn't get over until people get back in their seats. There is a real important question in here. What does ADRC have to do with Emory? We are the Alzheimer's Disease Research Center that is based at Emory University. Those of us who are providers or on the back of your program, we are faculty members at Emory University. Most of us are physicians. If we have MD after our name, we do see patients. We do participate in clinical research. If you're PhDs, you may be a clinical psychologist like our next presenter, or doing other studies. But the Goizueta Alzheimer's Disease Research Center of Emory University is Emory University. So all of us are Emory faculty. There is a question here about dementia and Benadryl. All I will say is that Benadryl is a medication that in older adults needs to be used very cautiously because it can cause things like mouth dryness, urinary retention, and constipation. So if you take Tylenol, take plain Tylenol, but not Tylenol PM because of the things that I just talked about. And as you get a little older, these medications have a different kind of effect, so it's not good. Which brings us to a question about sleep. Are medications, sleep medications like melatonin, zolpidem, okay to use and how often? Sometimes people do need something to help them sleep. And in consultation with your provider, it's best to discuss that with them and let them prescribe something for you. And if it's helpful, if it is, but it's not necessarily something you take chronically. And beyond all of that, if you have a pharmacist if you take medicines, you have a pharmacist. Make an appointment once a year, just like we talk about the annual wellness visit. Get a medication consultation with your pharmacist. That's somebody who can explain all of your medicines, everything that you've asked us about. Medicare pays for you to have a 1-year Medicare medication consultation visit that is paid for by Medicare. Which gets us to the last stretch of this program. We're going to get started with our last two presentations. Our next presenter is Dr. Felicia Goldstein. She's a clinical neuropsychologist. You heard about all that testing that Dr. Showalter alluded to, that Dr. Rodriguez talked about. We're always doing some kind of testing. Well, Dr. Goldstein has developed a lot of the norms, what's normal for somebody at this age, that age, and the other age, in our testing that's used across the country in the other 37 Alzheimer's disease research centers. So these neurocognitive batteries, these tests that we use to measure what your cognitive function is, have been developed by a number of very well-trained people. And we're happy to say that Dr. Felicia Goldstein, come up here, is one of them. She is the person that does the testing. Before you get to the neurologist, after you get to the family physician, you will see somebody like a Dr. Goldstein who does the brain testing and measures where you have deficits. Dr. Goldstein?
You may not want to stay for this talk because when Dr. Rodriguez was speaking, I realized I met all the criteria for being in the Pointer study. So I'm not maybe the best example. The other thing is last night some of us went out to dinner before the conference, and Jeopardy was brought up, and I was very disappointed to learn today that Jamie Ding did not win. So on that note, thank you very much for the invitation to speak today at the about the SuperAger Research Initiative at our 30th Emory Brain Health Forum. And what I want to do in this talk is tell you a bit about the scientific rationale and the overview of the SuperAger study we're involved with at Emory. Also give you some of the findings to date about SuperAgers and conclude with some takeaway messages. You know, our views of aging have really changed over the decades. In the 1900s, really senility was considered a normal an inevitable part of aging. If you lived long enough, you were going to become senile. It was just assumed that that was your outcome. And then in the 1970s, we saw a shift in thinking about aging, whereas dementia was looked at as a disease and not a normal part of aging. But there still was an option of you went from aging or to dementia, one or the other. We now know that there are many different trajectories of aging. And this slide just shows you some of the trajectories. One, obviously, as you get older on the bottom, you could see up to age 90 years. You could see that some people do go on to develop dementia. Some people go on to that middle stage of mild cognitive impairment shown by the blue bar. There's also normal aging. But there's also something called better than average aging, which is super aging, which is really what I want to talk to you about today. This slide just shows you a depiction of people trying to remember a story. On the left side, the vertical bar, you can see the number of story units that are recalled from this story. And the green represents what happens with normal aging. We know that there's a decline with memory with age. It's normal. All of us experience some change in our ability to retrieve information as we get older. And the green section represents individual dots or individual people. And if we look at that, we can see that there is a downward trend within normative limits still. But if you look at this circle here, there are also individuals who do better than normal. Those are the people outside the green. And what's really extraordinary about them is that they are performing at the level of much younger people in their 50s and 60s. This is what we're referring to as superagers, extraordinary memory ability. So the initiative that we're involved with at Emory is a 5-center study. The SuperAger study involves University of Chicago. They're the primary site. Emory's one of the sites. We have the University of Michigan, Wisconsin, and also Western University in Canada. And up to now, the SuperAger study has really enrolled almost 400 people across these different sites. And what we're interested in looking at is really what are protective factors for aging. We tend to focus in our research on what goes wrong with aging, on what dementia and mild cognitive impairment, the downside of getting older. But there's also a positive side, and there are people who are doing remarkably well despite being 80 and older. We're trying to figure out why is that, what's causing that. So in our study, we enroll people who are 80 years and older. The superager on the left is the person 80 years and older with memory performance at the level of someone 2 or more decades younger in their 50s and 60s. And we give you, memory tests when you come to us, and we are able to judge where you fall within that normative baseline. But they also have normal performance for their age in other cognitive domains, such as language and executive functioning. The second group of people that we recruit are cognitively average elderly adult. These are people 80 years and older who have normal performance, not only in memory, but other cognitive domains. So the real difference between those two groups has to do with memory performance. What we study in the SuperAger initiative involves a host of different factors. We're looking at predictors of superaging. People are asked about their personal and family history, their educational background. We also look at personality factors, lifestyle factors. When you come in, you're asked we draw blood from you, and we're looking at genetic factors that may separate superagers versus normal agers, inflammation that may be going on. Also, you're asked to do an MRI brain scan every 2 years, so we're really focusing on the brain and what's maybe different about it in someone with really successful, high, extraordinary memory. This just shows you a slide, and I mentioned there are almost 400 people across all the centers right now. But this is the demographics of the Emory participants. We actually have more than this. This slide was a little bit earlier. Yesterday I worked with a gentleman who's 94 years old and tested him, and he was just remarkable. I really enjoy this study. The people that we work with are phenomenal and very engaged. This just shows you our demographics. In terms of age, we have people, of course, 80 and older, 80 up to 94. Education tends to be a highly educated group, up to 1 year of college to 20 years professional degrees. We have about 61% females represented so far at Emory and about 38% Black and African American. And really why Emory was asked to join the SuperAger initiative is because of the success that we've had through our outreach corps led by Monica and Antoine about getting enrolled African Americans, because up to now the SuperAger project was really mostly white participants. And so we need to increase diversity and understand other lifestyle and other factors that may be contributing to SuperAger. So I wanted to briefly tell you what we've learned so far about superagers in terms of brain volume, their sleep, their exercise, and also features of their personality. In terms of brain volume, I mentioned people come in and they get an MRI brain scan. We've learned that superagers tend to have more youthful brains. So atrophy is common with a brain as we get older. Our brain does shrink some as we get older. And you may notice on a radiology report, if you've looked at them, the radiologist will also often comment on, generalized brain atrophy, normal for age. This is just the fact that our brains do shrink some. But the whole brain volume in superagers tends to be greater than in cognitively normal controls. In other words, they have healthier, thicker brain structure. And there's no difference between them and middle-aged controls, which is really unbelievable. We've also found that there's a region in the brain called the anterior cingulate. That's the purple little circle you can see in that brain on the left. This is an area that's very important to memory and attention, motivation, and emotion. And on the right, what's been found and replicated since is that in this particular brain region, superagers have greater volume of that region than do elderly controls. And in fact, they even have thicker regions in the anterior cingulate than middle-aged controls. They also have a slower rate of brain atrophy. I mentioned that brain atrophy occurs normally with age, but one of the investigators here, Amanda Cook, had people come back 18 months later and do brain scans, repeated brain scans. And what they found was that, if you look at the circles on the bottom, the rate of brain atrophy was actually twice as great in the cognitively average controls compared to the superagers. So it's a little bit slower rate of brain atrophy in superagers. What about exercise? That's come up a lot today so far. People in our study are asked to wear sensors. It's optional, but if you agree, you're asked to, for 2 weeks, wear sensors on you. And this is a really powerful methodology because we're not asking you to tell us how much have you slept, how much exercise are you getting. We're actually measuring it objectively. So through these sensors, it's been found that superagers exercise longer and more consistently. In terms of moderate, vigorous physical activity, superagers exceed the recommended levels of 30 minutes a day for adults over age 65 than cognitively average controls. And the other finding is that variability is lower in superagers, meaning that they engage in more consistent physical activity, about an average of 42 minutes of heart-pumping exercise each day. In terms of sleep, efficiency is another measure, not just of how long you're lying in bed trying to fall asleep, but how much you're in bed actually sleeping. And efficiency is actually better and more consistent in superagers. There's no difference, interestingly, in sleep duration, how long they're asleep between the superagers and the cognitively average controls. But the superagers have higher sleep efficiency. They achieve an efficiency score greater than 80%. And in contrast, sleep efficiency is more variable and less consistently good in cognitively average elderly adults. Personality is measured as part of the study. People are asked to fill out personality questionnaires. And here I've shown you one particular domain that seems to come out through that circle there. Superagers report more positive interpersonal relationships. They report more satisfying, warm, high-quality relationships. An example is one of the questions they answer positively is, I know that I can trust my friends, and they know that they can trust me. So takeaways from what we've learned so far, and it's ongoing, there's a lot more to be done. Question, is preservation of mental sharpness possible in persons 80 years and older? Yep. And do superagers have some unique characteristics that distinguish them from normal aging? They tend to, and we're seeing a few differences popping out now. But I wanted to emphasize in this talk that everyone in our study is 80 and older, and all of them are functioning normally. It's not just that the extraordinary memory, but the 80-year-olds that we call our normal controls actually are doing very well and are functioning within the expected norms for their age. So I really want to call both groups successful agers and not just focus on, the superagers. We have normal agers as well that are doing fantastically. What we found about both groups that don't differ is that average retirement age is 68.5. They tend to retire later, which is why they're going to have to drag me out of here on a gurney in 20 years from now. 87% are physically active, not just superagers, but successful normal agers, and 18% still are working after retirement. All of this, which has been a theme of our talks today by John and by Amy, talk about cognitive reserve. And we all know that cognitive reserve protects the brain. It can ward off the neuropathological changes of Alzheimer's disease, and it's critical. And again, to hit home the idea that all of these things matter, nutrition and mood, social contacts, being socially active, cognitively active, sleep, and physical exercise. And the final thing I do want to conclude with is that some days I amaze myself, and other days I put my keys in the fridge. Now, how many of you have walked around like this. Where are my eyeglasses? I can't find my eyeglasses. Or how many of us have called our neighbors and said, where's my phone? Can you ring my phone? The other thing I didn't show you is a picture, and I actually have one, of the day I wore 2 different pairs of shoes to work. They were both black. I took them out of the closet, and when I got to work, I had 2 different pairs of shoes on. This is just a part of normal aging. All of us have these brain glitches. We don't have to get panicked. I laugh them off, really. I try to just laugh them off rather than getting panicked. Oh, my God, something's wrong. It's just a part of aging, and it's a part of what makes it fun and challenging and fun to talk to our friends about, because they say, oh, yeah, I did that the other day. So eligibility criteria for the study are 80 years and older. We listed some here, and there's a table out front. You don't have to be extraordinarily at aging. You just, need to not have a diagnosis and be doing well. And you'll be asked to take memory, cognitive tests, complete questionnaires, undergo the blood draw and MRI brain scan. You're seen every 2 years for our study. You're also part of our Alzheimer's Center, so you're going to be followed yearly as part of that, too. And you'll be invited to wear sensors if you want. It's voluntary. You don't need to do that portion of the study. And you'll be asked to donate your brain. We tend to ask you upon your death, not while you're living. So this is optional, and you don't have to do it. But we would appreciate if you would give us your brain when you die so we could study what's extraordinary about your brain. I want to acknowledge particularly Dr. Parker and Dr. Trammell, who are co-investigators on this research. They're phenomenal. They guide the research, they guide recruitment, they have great ideas for what we need to be doing, and I really wanted to acknowledge both of them. And I wanted to acknowledge our staff, the Alzheimer's Center, the research people who put so much into coming in. We cannot get folks in, they are so busy that we actually have trouble scheduling folks because they have so many activities they're doing. They're so active, and they really are phenomenal in devoting time to our study. And if you're interested, there's also flyers out front, but these are some contact information. So thank you very much, and see what questions we may have. Right?
Sit over there. There's a microphone over there. Okay, we've been told that we need to sit in the chairs on the stage, and the microphone's over there, so go on over there. I'll come with you. Yes, you gotta go. Come on, if I gotta go, you gotta go.
Okay, here's one for you. Do superagers smoke weed?
Okay. Does smoking weed affect your brain? Well, it's probably not great, I have to say. I don't know. They have gummies now, too. It's probably producing, if you're at lower cognitive reserve, it's probably not the best thing to be doing. But honestly, there's research going on, and, I think, again, the idea is maybe moderation, alcohol, too. You don't want to do these things consistently every day, and you just maybe once in a while it's okay. It's an appetite stimulant, smoking pot. So I don't know really enough about that, but
No, you shouldn't go buy it on the street either.
Okay. So this has to do with profession. Do judges age better in their brain than teachers? Meaning that, if you have a higher level of education or occupation, are you more protected? Well, there is evidence that education does play a role, that high education is neuroprotective against getting Alzheimer's disease. But I think it's also a matter of what you do when you are in any profession. The amount of stimulation you give yourself, the things that you learn new, taking new courses, doing all sorts of work. So I don't think it's just about profession. I think it's about how you lead your daily life and the opportunities you open yourself up to. You know, in my profession as a clinical neuropsychologist, I'll get people who tell me that they only have a 12th grade education, but they had to leave their home, they had to leave to work on the farm or help their families and so forth. And these are the really bright people who have read all their lives, and so I don't know that it's just about profession, but basically what you do. For someone in their late 80s or into their 90s with MCI, can lifestyle changes such as exercise, diet, etc., reverse MCI symptoms as opposed to slow them down? Well, I think John's a great example of this with his mom. I mean, his mother did meet criteria for MCI, and he did implement the program with her, and it did actually reverse some of the changes. She was doing very well on her testing. He said normal, and we've seen other examples through his talk too of people who did have some cognitive problems and benefited. So I tell people it's never too late, and you don't have to have normal cognition for these things to work. MCI definitely can benefit from these lifestyle changes, and I hope that's a take-home message from today's talks. Are superagers experiencing Alzheimer's less than average? That's a great question. We're looking at whether or not genes are, you would expect that the genetic predisposition for Alzheimer's would be less in a superager than in a normal elderly control. The studies that we've done in our group have not found this, actually, that the E4 allele, or which is the risk factor for Alzheimer's, or the E2 allele, which is a protective factor, is less in superagers than in normal controls. However, I will say another study from another group has just published the opposite. So we're really trying to study this and figure out what, eventually people are being followed every 2 years, and we're able to track what's going on. And I think eventually the more people we track, the more we'll be able to figure out who is more at risk for Alzheimer's and who is not at much risk. But we don't quite have those answers yet because we don't have enough longitudinal data. Brain volume and atrophy are positive results of lifestyle. Well, I will say that brain atrophy and volume, if this is the question I'm interpreting correctly, can be slowed down with exercise and some of these other lifestyle changes. And in fact, in some of the clinical trials that Dr. Rodriguez presented, some of the outcome measures had to do with measuring the brain every few years. And they did notice a slowness in atrophy with these changes. So yeah, they can affect brain structure and function too, how well the brain communicates, the different parts of the brain communicate. That's also been looked at.
I have a question here, and it's a general question. In Dr. Showalter's presentation and Dr. Rodriguez's presentation, smoking is a risk factor for developing dementia. So whether you're smoking tobacco, weed, or vaping, it's all bad for you. So that's the take home on that. So is it okay if I vape this, that, or the other? It's still smoking. It's still bad. It's toxic for your lungs.
Exactly, and it cuts down on your oxygen, ability of the oxygen to reach the brain, so it can't be good in that respect. It also increases your risk for vascular disease and stroke. So common sense answer, no.
No.
You don't want to smoke. And I used to smoke pretty heavily, but gave that up about 20 years ago, and I definitely can feel the benefits of that.
Hormones.
Health benefits. Were there any apparent differences in hormonal levels? Excellent question. Of women and superagers. Don't have the answer yet. Sex, female-male differences are really being investigated to find out. if there are sex differences. That's a big goal, too, of the NIH now. They insist that in your grants now that you propose to look at sex differences, but we don't have that yet. But we are measuring hormone levels and so forth, so hopefully down the road we'll have some answers.
We
to
can't
that.
really say that we're talking about sex differences. That's one of the things. You can't really do a whole lot of women's health. That's one of the things that's not really allowed us to do here lately, but in theory, we support it.
Sleep latency, time to sleep versus sleep efficiency, which is more important for brain health? I'm not a sleep doctor, but I would say sleep efficiency is more important. It's when you get into bed, how well you're actually sleeping when you do fall asleep matters. You know, not just lying in bed thinking about, oh, I have to go to sleep, but when you do fall asleep, are you able to get good restorative sleep to clean out the toxins in the brain and really feel rested when you wake up in the morning?
When Dr. Antoine comes up with his remarks, he's going to address that question more fully.
Yeah, yeah.
Okay, and I think this is it for us, right? Okay.
Okay, thank you for your attention.
Thank you, Dr. Goldstein. Our last presenter today is Dr. Charles Winden. He is a internist at the University of California, San Francisco. And this is a part of our presentation where we're going to learn about how brain images, or brain x-rays, if you will, are used to predict who gets Alzheimer's or not. Dr. Winden? Okay, he's up there.
Can you hear me okay?
Yeah, there you are. Welcome.
Wonderful.
We hear you and we see you.
Great. Okay. It's good to see everyone. My apologies for not being able to make it there in person, but really excited to be able to speak with you about really imaging biomarkers for Alzheimer's disease, but we'll be speaking about these in the context of a very important research study, which is the Alzheimer's Disease Neuroimaging Initiative that has been running for more than 20 years approximately. I cannot advance the slides myself based on the format, so I'll just ask for whoever's in control to advance to the next. Go back one. There we go. So you've heard a lot of great content this morning, but the fact of the matter is that the burden of dementia is growing tremendously. There are currently over 55 million individuals living with dementia. That number will triple by 2050 unless we develop more effective interventions. Greatest risk factor, of course, for dementia being age in and of itself. There are a number of other risk factors, but the greatest risk factor for the development of dementia is age, and many individuals in many parts of the world are aging. One of the challenges we know, however, is that clinical symptoms alone are not enough with regards to making a diagnosis. So when we look at somebody who's having memory loss, when we look at somebody who's having problems with regards to organizing the house, problems with regards to getting around in terms of their neighborhood, etc., many times these changes are occurring after changes in the brain have already started to take place. What we also know is that not all things that are memory loss are Alzheimer's disease. And Alzheimer's disease itself does not always cause memory loss predominantly. It can cause other symptoms. And so imaging really has made a significant impact in this regard, in that we're better able to understand this idea of Alzheimer's disease as a biological condition. And you can see the reference to the article here on the right-hand side. Really, we have started to look at Alzheimer's through this lens of what is the actual underlying biology, not what is necessarily the clinical symptom that somebody's experiencing, what is going on in the brain in and of itself that's actually changing from a biological standpoint, and how do we visualize this with different tests. Let's go to the next slide. Other way. Oh, other way.
Sorry.
There we go. Oh, back one. There we go. Forward one. There we go. So how did ADNI even begin? So ADNI was launched actually all the way back in 2004. And it's a very unique study in that it is a study that's a public-private partnership. So there is funding coming through different streams. There is private pharmaceutical companies, industry, et cetera. But there's also public, the NIH. You've heard of the NIH, of course. And so these entities came together to form ADNI, and ADNI, the goal of it really was to better understand Alzheimer's disease and the progression of Alzheimer's disease using biomarkers. It is a multi-site project. It's quite a large project, actually. There are more than 50 sites around the US and Canada. It was originally started by Dr. Michael Weiner at UCSF. And again, at its core, ADNI's entire goal was to develop, validate, and standardize not only MRI, but PET, CSF, and now blood-based biomarkers for early Alzheimer's detection. I want to call attention just to a couple of things. One, the development of different imaging biomarkers. Without the tremendous amount of data that ADNI has generated, we actually wouldn't have many of the Alzheimer's imaging biomarkers that we are able to use now, not only in research, but even in a clinical setting. The other thing I want to call attention to is really the idea of standardization. So imagine this. You go to a doctor's office to have your blood drawn. You get a blood test looking for, say, your hemoglobin A1C. It reads out a specific result. You go right down the road on the same day within the same hour to another, basically, lab and have your blood test done for your A1C there. But your A1C is vastly different compared to the blood test that you got done earlier because there's no standardization of how they're doing in the A1C testing. One lab is doing things completely different from the other lab. You can see where the issue arises in this example, where which is the true A1C value, right? How do I know this A1C value is actually representative of my underlying biology? Prior to ADNI and a lot of the work that's been done around ADNI, that is really a big challenge that was in the Alzheimer's field when it came to imaging. There was a lack of standardization. So we could see things and interpret things based on an image, but somebody could go and get a scan at another place and show something drastically different. And again, in that example, how do you know which is truth, which is truly representative of what's going on with the individual? I have another article here on the right-hand side that came out just not too long ago, really showing the 2 decades of impact that ADNI has had and how ADNI will move forward. We can go to the next slide. So ADNI has occurred in a number of different phases, technically 5, ADNI 1, ADNI Go, ADNI 2, ADNI 3, and ADNI 4. And at each stop along the way, there have been more advancements really in the imaging biomarkers of Alzheimer's that have been made. So ADNI 1 started off all the way back in 2004. As I mentioned, really key to this was the standardization of image acquisition. So how we're actually taking the MRI picture, how we're actually doing an amyloid PET, so to speak, standardization of that across the board so that there's consistency. People are doing this the same way each time, so there's not tons of variability. ADNI 1 also validated that MRI could be used as a longitudinal measure. So following somebody who has cognitive problems, memory problems over the course of time, where you're suspicious that they may have Alzheimer's disease, using MRI at different time points to track how is the brain changing, ADNI validated that we could actually do that. ADNI 1 also looked into amyloid PET feasibility. So can we actually visualize, can we actually see amyloid pathology in the brain? Amyloid pathology is one of the hallmarks of Alzheimer's disease. Can we see this in the brain on a PET scan before somebody actually ever goes on to have an autopsy where they see it thereafter? ADNI Go and ADNI 2 expanded upon this. They started to march back essentially the symptom severity. They looked at individuals who were much less impaired in terms of kind of their cognition. ADNI 2 and ADNI Go validated that amyloid PET is a reliable measure, and we started also to look at more advanced imaging measures in MRI in ADNI Go and ADNI 2. ADNI 3, we start talking about tau PET. So again, Alzheimer's amyloid pathology is one hallmark, but the other hallmark is really tau pathology. So ADNI 3 started to look at, can we look at tau PET measures over a long period of time, and is it valuable? There was also more validation of amyloid PET in ADNI 3. And ADNI 4, which is currently ongoing, which started 2022, really expanded the inclusivity and diversity in the cohort of ADNI. We had greater expansion of the different PET tracers for amyloid and tau, and more protocols looking at the vascular contributions to cognitive impairment. We heard earlier about how so many causes of dementia vascular disease actually is driving the cognitive symptoms. And the rule is actually that most people who have cognitive impairment, who have Alzheimer's disease, they have what's called mixed pathology, meaning it's not just the Alzheimer's disease by itself causing issues, it's the Alzheimer's disease plus something else. And most often that's actually vascular disease. In many instances, the vascular disease itself being primary. We can go to the next slide. So what does this look like? MRI in terms of looking at structural imaging. So I mentioned standardization. ADNI really helped us to establish rigorous protocols where people are doing the imaging the same way when it comes to research trials. Again, critically important. We're trying to understand how somebody's brain is changing over the course of time based on their MRI in the setting of a research trial. It doesn't help if everybody's doing the MRI scan a different way and we're getting all types of different results. As I mentioned, ADNI was critical in helping us validate that you can actually look at atrophy. You can look at change in brain volume over time, and this is actually a good biomarker with regards to neurodegeneration and progression of Alzheimer's disease, specifically hippocampal volume. So you see here on the right-hand side, a couple of different pictures. I'll go column by column. The far left-hand column, you're looking at two pictures. The top row is if you were looking at the brain of an individual standing right above them. The bottom row is if you were looking at the brain of an individual looking face on to them. And so in the healthy column, in the healthy control individual in the far left column, you see the brain is nice and full. There's lots of gray and white coloring that fills out basically the entire intracranial vault. When somebody has mild cognitive impairment and turning into dementia, ultimately in some instances, those are the additional columns on the right-hand side. So in the second column, this is actually the MRI of somebody who might have pretty classic Alzheimer's disease, where you see that there's a difference. There's a lot more of this kind of black, dark coloring within the intracranial vault. That's fluid-filled space. It's space basically where the surrounding brain tissue has become more contracted. That face-on view is particularly interesting because we can actually see the hippocampi, which are kind of down on the bottom, so to speak, of the image. We can actually see the hippocampi, and they have shrunken specifically as a result, likely of Alzheimer's disease. There are other imaging patterns that we can see, though, when somebody has Alzheimer's disease. And a lot of this work has come through ADNI, where people can have what's called a limbic predominant, meaning it really goes after the hippocampus and the surrounding area. You can have hippocampal sparing, where actually that hippocampus looks more full and more healthy, but the rest of the brain is really taking the hit, so to speak. And there are some individuals who have very minimal actually changes on their MRI, but when we look at other measures, they still actually truly have Alzheimer's disease. And we'll talk about that in just a bit with amyloid and tau PET. We can go to the next. So how do we actually look for this pathology, right? I mentioned amyloid and tau, the two pathological hallmarks of Alzheimer's disease. Can we actually see this pathology on something like a PET scan? And the answer is yes, we absolutely can. Thanks to a lot of the work that has been done in ADNI, there are now amyloid and tau PET scans that you can get not only in research, you can get this in an actual doctor's office. And this really is becoming the standard of care, where somebody, when they come into the doctor's office and there are concerns about memory and thinking problems, we do the appropriate assessments and we find, yes, there truly are problems based on tests. We find an MRI that also doesn't look necessarily the greatest. Really, we should be doing biomarker testing. We should be doing either a blood-based test or an image test to better understand, do they have Alzheimer's pathology in the brain? So ADNI was pivotal, really crucial in terms of validating now FDA-approved PET tracers and ensuring that they're reliable. And it also helped with regards to standardizing thresholds. So one of the questions that comes up is, okay, when I get a test done at the doctor's office, the test can either be abnormal or it can be normal. Many of us are used to this idea from other things like blood tests, etc. How do we apply that, though, to a PET scan? What is considered abnormal, quote unquote, and what is considered normal? And so ADNI has been helpful in terms of helping us develop thresholds whereby at this number, we decide that the test is actually abnormal or there's a likely presence of this amyloid pathology compared to somebody who might not have it. So on the right-hand side, what you're looking at you're actually looking at a real PET scan from an individual, two individuals technically. The images on the left-hand side are from individuals who have basically a normal amyloid PET scan. And what that means is that there's an absence of this abnormal amyloid pathology building up in the brain. We're not seeing it take up a whole bunch of real estate in the brain. On the right-hand side, what you see are images from an individual or individuals who truly actually have underlying Alzheimer's pathology. Specifically, they have amyloid pathology that is taking up significant amounts of real estate in the brain. And you can see this, right? This is a very simple comparison. The images on the left, there's a lot more green and yellow and kind of dark blue. The images on the right, what do you see? There's a tremendous amount of red. There's a lot of red and sometimes very dark coloring red that almost kind of hovers around the black color, so to speak. And so we can see just looking at these two different images or sets of images, how powerful the technology is that we now have available. And a lot of that, again, really comes through the work that has been done in ADNI. We can go to the next slide where we talk about tau PET. So again, amyloid PET, looking at amyloid pathology, amyloid protein buildup in the brain. Tau PET, looking at tau pathology or tau protein buildup in the brain. So ADNI has been very helpful in helping us demonstrate that, hey, we can actually, with a tau PET scan, look at how the tau proteins start to change in the brain, how they continue to build up over time. Why is this important? Well, we know that tau pathology is actually a much better predictor of cognitive decline than amyloid burden. There are studies that suggest that amyloid pathology starts to build up 15 to 20 years before somebody ever has a memory symptom. But what we know based on, again, a lot of the work from ADNI and other research projects, once the tau protein really starts to migrate out into different parts of the brain, then the cognition and memory really starts to change. And so ADNI has been really critical for this. The images that you see on the right, these are tau PET scans just in different orientations. The top row, again, if you were looking down at the top of somebody's head, the middle row, if you were looking at the side of somebody's head, and the bottom row, if you were looking face on essentially at them. And what you see is that the areas that are colored with regards to kind of red and yellow and a little bit of orange, those are actually areas where you're looking at tau pathology. That is actually the tau pathology of Alzheimer's disease that is starting to take up space in those different regions of the brain. And you can see that visualized clearly here. Again, credit to ADNI for helping us with regards to the development of these tracers and their validation and their use. Again, these technologies are available in the clinic. You can actually obtain an amyloid PET scan and a tau PET scan in a clinic through your doctor. They are fully FDA approved at this point. The research continues to better them, continue to make them more effective, but you can actually get these in the real world currently. We can go to the next. Just a little bit of a note about a couple of other things. So ADNI has helped us with regards to exploring additional MRI measures, things like diffusion tensor imaging, functional MRI. We won't go necessarily into all the details of them because we don't use them necessarily heavily from a clinical standpoint, depending on where you are. But we're trying to get more into advanced MRI measures because we're trying to better understand, again, all potential pathological contributions that can impact somebody's memory and thinking ability. And so we can better understand potentially things like vascular contributions to memory and thinking impairment through some of these MRI measures, but we have a lot more work to do. One of the most important things that has come out of ADNI is this idea of the what's called ATN framework. And this is largely used in research, but it does have clinical implications. ATN really referring to amyloid tau neurodegeneration. So how much amyloid is present? Is it present, yes or no? How much tau is present? Is it present, yes or no? And then what actually is the neurodegeneration of the brain looking like? How much volume change are we seeing in the brain? And as we've walked through, you can see how each imaging test we've talked about contributes to this framework. You can use amyloid PET, tau PET, and you can use MRI to help you with regards to this ATN framework. Why have an ATN framework? Again, this is all part of the larger idea of shifting our paradigm of Alzheimer's disease from just a clinical syndrome somebody's having memory loss, confusion, etc., to a true biological entity, right? And that's the key. We think about this in other conditions almost second nature. If somebody has cancer and they have nausea as a result of their cancer, the primary problem is not the nausea. It's not the symptom. It's the underlying cancer that's the primary issue. That's the disease process. It's the same idea with Alzheimer's disease, and we're trying to slowly but surely continue to move in that direction and really cement that in folks' mind. It's a biological condition. It's an actual disease process that can cause many different types of symptoms downstream. We can go to the next. Just a couple of final notes about ADNI and what makes ADNI special. One of the things that's unique about ADNI and why we've made so much progress in some of these imaging tests over the course of 20 years is that ADNI really promotes the idea of team science and sharing. So ADNI allows individuals to download data at will. It can essentially, the data can be used as long as credit is given to the ADNI basically team. There are more than 5,500 publications at this point that have been generated using ADNI data. And as I mentioned, it really is the cornerstone and the foundation of so much of the advancement that we have really benefited from over the course of the last 2 decades. The other thing about ADNI is that because of this open access model, individuals from anywhere can really make a meaningful impact in the field. You don't have concentrations of essentially the research data any longer where you have to have tons of money and tons of resources and only be located at a certain area to be able to access this data and be able to make a contribution. That's not the case. The smallest research institution with the smallest team of individuals can still actually access this data and help move forward the science, which benefits us all. And then finally, we'll go to the next. So just a couple of final takeaways and future directions. So what is ADNI's legacy? It really has helped with regards to the development, validation, standardization of a number of biomarkers that we benefit from today. The idea of being open science is absolutely paramount. Prior to ADNI, if you look back at the landscape, open science was a relatively new concept. ADNI has really started to make that essentially the standard. And it really has transformed trials as well. I didn't reference this too much, but when we do clinical trials, many of the clinical trials currently ongoing to better investigate things like amyloid removal therapy, tau removal therapy, etc., they are based in many ways on ADNI protocols, on ADNI imaging, basically standardization, et cetera, et cetera. So it has allowed us to do better science as a whole. ADNI is trying to be more inclusive. All of our Alzheimer's disease and dementia research needs to be more inclusive. This is obviously, I think, clear to many of us, if not all of us. ADNI also is making a significant impact in blood-based biomarkers. So there are now blood-based tests, which you heard about a little bit earlier, that can be used, and ADNI is helping with regards to progress in this area. And also digital health, right? We realize that we are living in a world that is becoming increasingly digital, especially post-pandemic and with the advent of AI, and ADNI also is moving into this space to better understand how can we use these digital health technologies really for the purposes of research and also better cognitive health for all. And so with that, I'll go ahead and end here and happy to entertain any questions that may have arisen.
Thank you, Dr. Winden. I will read them as they get over here. I know he said ADNI a lot, so ADNI, Alzheimer's Disease Neuroimaging Project. Okay, and as we saw, we've been doing this neuroimaging project, this specialized X-ray project, since 2004. And Emory University's Alzheimer's Disease Research Center is one of the centers, one of 37 centers in the United States that's doing this kind of research. So if you participate in research here, chances are you certainly get an MRI. Depending upon the study, you may get an amyloid PET scan and or a tau PET scan. If you are being treated, Dr. Tremel's coming up here so he can lead this bunch. Come on, get you up here. Amyloid, see, he's my mentee, he's getting there. You will probably be eligible for any of the imaging studies that we have. Here at the Alzheimer's Disease Research Center, we do MRIs, we do the tau PET scan, and we do the amyloid PET scans as part of our research. There are several studies that we're recruiting for that do these images, whether or not you have a neurodegenerative disorder. So, first question, Dr. Winden, will Medicare pay for the tau PET scan or the ATN framework, the amyloid tau neurodegenerative framework?
Sure. So that's a great question, a very important question. What we've experienced at our center is that Medicare will cover amyloid PET according to their traditional kind of 80/20. And so most folks who we see have Medicare and then they have a supplemental, and so they don't end up paying out of pocket. But Medicare will cover according to their traditional 80/20. The tau PET scan, although it is technically FDA approved, it is not yet fully reimbursed and covered by Medicare, which is a major issue. There are many of us who are active in essentially kind of the advocacy and policy space as well, who are trying to change this, but it is not yet fully covered by Medicare. That being said, through participation in different research projects like ADNI and others, you can actually get a tau PET scan that doesn't cost you anything at all. So there are other means of obtaining it, not yet fully Medicare covered.
Okay, one of the questions, you talked a lot about standardization, and the question is, does it matter where you get your MRI or PET scan?
So I'm trying to choose my words carefully in this scenario. My personal opinion is yes. And the reason for that is because with regards to amyloid and tau PET scans, it really is, it comes down to interpretation, right? You need to have the scan performed appropriately first and foremost, so different procedures need to be followed appropriately. Amyloid and tau PET scanning also is very dependent on time. You have to basically obtain the image at a very specific time after you receive the injection of the radio tracer. If you don't do that, you can't actually interpret the test. So you need to do the test appropriately, but then you need to actually have a team who's reading the image that knows what they're doing. And so we have had experiences where individuals have had amyloid and tau PET scans done at certain centers, and then we actually have to reinterpret the entire scan because it's been misinterpreted. And so I would say the general rule of thumb is you're looking for a center that has more experience in doing these tests. They are still relatively new. They're not widely available everywhere. And so a lot of times it is going to be an academic center. That being said, there are other places outside of academic centers where you can get an amyloid and a tau PET scan. I would really lean towards places where they have more experience doing the test, more experience interpreting the results, because you can get misinterpretations just like any other test, right? It's no different from any other test, but I think amyloid and tau PET scans a little bit more tricky because the technology and whatnot continues to advance rapidly. They're not widely available everywhere, and you need to kind of know what you're doing when you order them and interpret them.
And on that note, there are 37 different Alzheimer's disease research centers in the United States. We're the only one here in Georgia, but there's one closest to us is Alabama, and Florida has several, which includes the Mayo Clinic. But anywhere there's an Alzheimer's disease research center, most of the providers in that center have the same level of standardization for conducting the amyloid and the tau PET scans. On that note, can changes in the brain be seen with vascular dementia? We talked about Alzheimer's dementia with the tau and the amyloid. What about vascular dementia? How do these scans fit into vascular dementia?
Sure. So many times when somebody has, vascular disease, cerebrovascular disease in the brain that we suspect is the primary cause of their dementia, we see more changes on the MRI. So you can see, we didn't go through all of the different components of the MRI, but there are different sequences in an MRI. So you can look at one sequence that shows you, more broadly whether or not there's significant volume loss. You can look for atrophy patterns. You can also look at different sequences on the MRI that look specifically for changes that are suggestive of basically cerebrovascular disease. So a lot of times when we're counseling folks and we're talking about diagnosis, we will reference their MRI if we are basically concerned that they have cerebrovascular disease causing their dementia, and there are certain findings on the MRI. That being said, I will say this, we do not have the greatest biomarkers for cerebrovascular disease as the primary cause of impairment. My own personal opinion, it's still very basic in terms of how we actually look at biomarkers of cerebrovascular disease. There are a lot of individuals actually in this space who are trying to develop more sophisticated MRI measures, blood-based tests, etc., so that we can become a lot more exact in our diagnosis, but we have a lot of progress still to make in this area.
Good morning, Charles.
Good to see you again.
You as well. Thank you for this talk. I know it's early in the morning for you in San Francisco. So which should you get first, amyloid PET or tau PET, regarding the ATN framework?
Sure. So generally, when we engage with folks, our diagnostic process always starts with a history and physical examination, right? So if you are being evaluated for cognitive changes, concerns for dementia, first and foremost is always having a provider talk with you at length about what is going on. There is no substitute for that. Okay. I think that's really critical to emphasize also because no test is 100% accurate, period, in medicine. That does not exist. So you need somebody first and foremost to start to put together a history of what is going on. Very often after that, we will do some sort of cognitive testing, or even before. You heard about neuropsychological testing and the things that can be done to better understand where somebody is experiencing difficulties. We will typically obtain an MRI before we do any sort of PET, at least at our center. And again, that's to better understand from a structural standpoint, are there clear things that are issues, right? You could come in to see me, for example, and you have a massive brain tumor in one of your temporal lobes, and that's the reason for all of your cognitive concerns and changes, right? Or the primary reason. So we always start with an MRI looking for kind of the most easy to identify things. We then will go to amyloid PET. There's two reasons for this. One is actually insurance. Again, it's covered by Medicare. And so folks with Medicare who have supplemental also, which is many of the folks we take care of, they don't pay anything out of pocket. This is very easy to order. It's very easy to obtain. The tau PET we will use, but it's reserved for more specific instances. And so what do I mean by that? One, we have to deal with the idea of cost. There have been scenarios at our center where we've been able to get a tau PET actually covered financially. It requires a lot of paperwork and other things, but we can get it done. I will sometimes order a tau PET when I want to better understand, is this person going to be a good candidate for therapy? What I mean by that is we have medicines now that can lower essentially amyloid burden, but those medications have a narrow window. They're not curative. There are a lot of side effects. If I have somebody who I'm on the fence about in terms of whether or not they'll really benefit from the medication, especially if they have a very high risk of having a side effect to the medication, I'll get a tau PET scan. The reason is because if I see they have lots of tau all over the brain, I'll tell them, look, you already have a significant amount of tau throughout the brain. The likelihood this medication is going to significantly benefit you while also keeping in mind, keeping your risk profile as low as possible is probably pretty minimal. And this may not be the greatest medicine at this point. And so clinical evaluation, cognitive testing, MRI, amyloid PET, and then tau PET is really end of the line. We don't typically jump to tau PET right off the bat. The other thing about it is that in many instances, if somebody has a positive amyloid PET, they have some level of tau pathology already. And so you can kind of hedge. That's not the case for every single person. I don't want to make that generalization. But depending on the clinical scenario, sometimes I don't need the tau PET. I can kind of guesstimate as to you probably have some level of tau PET, and it's probably in these areas, et cetera. But it's still a useful test, of course, to use when appropriate.
Right. So earlier in your talk, you mentioned that tau can drive symptoms more so than amyloid. And we have amyloid-reducing therapies. Well, is it possible to reduce tau or treat accumulated tau as well?
Sure. So there are many researchers and scientists who are working specifically on tau modifying therapies. So this is not new. Individuals have been trying to find medications that effectively reduce tau protein, which again, we think more strongly links to cognition. We just don't have one that is FDA approved as of yet, but there are individuals who are working in that space.
Are the anti-amyloid infusions helpful in delaying progression of early onset Alzheimer's?
So I think the question that I would ask in response to that is what is meant by early onset? Are we talking about kind of classic, less younger than the age of 65 Alzheimer's disease that we're referring to in early onset?
Yes.
Okay, just because some folks have different definitions of early onset, even though the definition of early onset is pretty universal, I feel like. So in the clinical trials that were done, looking at essentially the amyloid removing therapies, so you have to keep in mind that the clinical trials that were done for lecanemab and donanemab, which are the two FDA-approved anti-amyloid therapies, they were done differently. And so the main difference is that in the donanemab trials, they knew actually the tau burden of individuals. They knew how much tau individuals were walking around with. That being said, to the question of early onset Alzheimer's, there were individuals in both trials who had quote unquote early onset Alzheimer's disease. And so when you look at the compilation of everybody together, yes, there is some evidence to suggest that the amyloid lowering therapies have benefit in slowing progression among individuals who have early onset Alzheimer's. The caveat to that, and the thing that's important to keep in mind, is that people with early onset Alzheimer's disease are sometimes a little bit different compared to folks who have Alzheimer's disease that starts later in life. Our research in our center has shown that people who have early onset Alzheimer's oftentimes have more aggressive disease. So by the time they actually get to an evaluation, one, they have more baseline pathology. They already have very high rates of amyloid already. A lot of times they have, a semi-decent amount of tau, but they also seem to have more aggressive disease in that they seem to decline more quickly over time. And there is even some suggestion based on some of our data that they tend to accumulate pathology more quickly too. So they start off with higher pathology. The amyloid doesn't necessarily continue to go up rapidly, but the tau does. We see that the tau really takes kind of an aggressive trajectory moving forward. Does that mean that they won't benefit from an anti-amyloid therapy? Not necessarily. Again, we have data to suggest from the clinical trials that they could, but this is where you really get down to kind of personalized and individualized medicine, right? If you have a really high amyloid burden, but you also have a very, very high tau burden, and you have a lot of risk factors for a side effect from one of the anti-amyloid therapies, I actually might tell somebody this may not be the best medication for you because you're more likely to have a high side effect. You're more likely to have a side effect because of your high risk profile, and the benefit you may obtain for this, I'm actually not 100% sure because you have so much tau pathology already.
Got it. So last question, would you like to say anything about the Team ADNI initiative that's in the pipeline?
Sure. So just I can share briefly. We talked about ADNI kind of extensively. One of the things about ADNI to keep in mind, and one of the things to keep in mind about most of our research in Alzheimer's dementia, it is very heavily geographically based, meaning most often you have to physically go to a site to be able to participate in the research project. Why is that an issue? It's simple. It limits access, right? If you live in a very rural area, if you're limited in terms of mobility, if you're significantly limited in terms of transportation, right? All of these things play into, well, maybe I want to participate in a research study, but I actually can't because I can't go to the place where the research is being done. There's a new initiative that's been started actually in ADNI that is called Team ADNI. Team ADNI's entire goal is to try to help with this barrier. So Team ADNI is trying to, one, recruit more individuals who have essentially a more diverse educational profile. Most individuals in ADNI and most individuals in most Alzheimer's research projects, college educated, have advanced degrees, et cetera, et cetera. That's not the majority of the U.S. population. I think it's something like 60% of the U.S. population above a certain age only has 12 years of education. And so we're missing an entire segment of the population. Team ADNI is trying to recruit these individuals specifically, also trying to recruit individuals from more diverse socioeconomic backgrounds. And a big part of Team ADNI is actually the remote assessment part of Team ADNI. What does the remote assessment Team ADNI look like? You never go into a clinical site. You do every single procedure actually just through a telephone call. So you don't have to be technically sophisticated in terms of Zoom and all of those things. You don't have to physically go to a site. We do everything top to bottom just over the phone. And so it's a pilot to better understand how well can we characterize individuals and what kind of quality data can we gather through this completely remote arm? And the hope is that we can actually build something that other individuals can use in the future so that their research is more inclusive. And we just started actually Team ADNI as a pilot within the last month or so.
All right. Thank you. Have you enjoyed the forum today? Good. Wonderful. So I am Antoine Trammell, and I work with Dr. Parker in our outreach core. I co-lead it with her. I'm also an investigator for several studies at our center. In fact, I am the lead for ADNI here at Emory, and we are one of the sites for Team ADNI. And again, I really appreciate Charles making the time to speak, given the time difference. He's a friend and a good colleague, and I asked him to speak, and he showed up. So thank you, Charles. Now, in addition to the work that I do in outreach, I also lead a Georgia MemoryNet clinic here in Atlanta, located at Grady. And if you haven't noticed, a lot of us wear many hats. I'm no different. And, I wear many hats simply because I find joy in helping people get hope and meaning in their lives, because it gives me hope and meaning for my life. Now, one of the major goals of, I hope everyone in this room, is to be able to wipe your own behind as you age. That's, you laugh, but it's truly a serious thing, right? And I think that today we learned a lot of things that can help increase the chance that we will be able to do that for ourselves. We learned a lot of things that can increase joy and meaning in our lives. We learned that small steps that we do each day can prevent or delay memory changes if we have them. We learned how lifestyle can affect memory changes for the better. We learned about superaging, that it's not inevitable to become old and senile. That's wonderful. We also learned how technology and brain scans can help diagnose problems even before the symptoms occur. So it's a lot to think about. But what it really boils down to is that while aging is a part of life, we have the power to age well. We have tools within our reach. We have knowledge at our disposal. We can figure out what's going on. And once we figure out what's going on, we can take steps to do something about it. And it doesn't have to be expensive drug therapies, no offense to the pharmacists in the room. But lifestyle, games, stimulating your brain, picking up an instrument, those are things that are within our reach that we can do. Learning a language. We talked about the democratization of data, but this is the democratization of interventions. You are empowered to do something, and I hope you take that away from the time that you spent with us today. You can take action, and really and truly those actions are just small steps, small changes that Dr. Rodriguez mentioned, one step at a time. But those small steps, one day at a time, can lead to large effects. So Dr. Showalter mentioned picking up an instrument. I want to share something about myself. Music is one of my passions. I first picked up a guitar when I was 13 years old. I'm not 13 anymore. I was helping my 8th grade life science teacher clean out a closet, like a storage room, and there was this old Yamaha classic acoustic guitar. I'm like, hey, is that yours? And she's like, you know what, you want it? Take it. And she gave me a gift of music, a gift that can help my brain as I age. So over time, I will admit that when I first got the instrument, my first thought was, now I'll get some attention from the girls. But as I got older, it became much more significant to me. And I acquired many more. I have acquired many more guitars since then. And when I finished my chief residency, and I stayed on for a research fellowship in cardiac arrest at my institution. To celebrate, I wanted to buy another guitar. So I went to eBay because I wanted something with a little character. And I saw this Gibson classical acoustic. I learned to play on it on that type of guitar, meaning it has nylon strings and somewhat of a wider neck. So I bought it. And I don't think the person on eBay knew what they were selling. Maybe they did, maybe they didn't, but when I got it, the first thing I wanted to do was look up the serial number, make sure it was real. And to my surprise, it was made in 1915. So I took it to a shop. I'm like, man, I looked this up. Is this really made in 1915? They're like, yeah. It was really made in 1915. It looked pretty darn good. What's special about that year or that era, does anyone play instruments? Guitar, any, okay. So in the 1920s, they started to put these metal rods in the neck of guitars. And it's to keep the neck from bowing or warping. Well, the guitar that I have, because it was made in 1915, it doesn't have that. So the neck is slightly warped a little bit. Whenever I tune it, I have to tune one of the strings flat as a result. Even though it's warped, it still plays beautifully. My point is, just because it's aging and it's imperfect doesn't mean that it lacks beauty, strength, and vitality. Okay? That's my favorite guitar. I have over 20 now, but I play it almost every day, and I keep it in a special place in my house. Just like that guitar, we will develop imperfections and blemishes as we age. But that doesn't mean that say it with me, our beauty, our strength, and our vitality will fade. No. So as I wrap up, I want to circle back to something I said at the last forum, where I asked everyone to look up and look down, and some people may be like, what is he talking about? The point was, up and down are both the same thing in concept, their direction, okay? And everyone in this room, we are the same, we are people. We have different titles. You may be doctor, scientist, research participant, patient, but we are people working towards a common goal. Beauty, strength, and vitality as we age. To me, that makes us a community. We are a community dedicated to our success. Whatever your title may be, we are working towards a common goal. And standing here looking at all of you, from my vantage point, we are succeeding. So, to everyone in this room, I want to say thank you. Because you are supporting our community. We are supporting our community. And in that, I want to acknowledge the work of our center leadership, like Dr. Parker, Dr. Goldstein, Dr. Rodriguez. I also want, loved her talk. I also want to take the time to acknowledge the people that you may not see, the outreach team. No applause for them? The communications team, our study coordinators, they're people working behind the scenes to make sure that your study visits go well, to make sure that the data that we get is accurate, so that when we're up here sharing things that can help you maintain your beauty, strength, and vitality as you get older, that is right, that is accurate. We also have community partners. And we have some community partners in the room that I would like to acknowledge as well. We have some great administrators here. So back in May of 2025, as a matter of fact, May 5th, 2025, I moved my clinic from the main Grady to the Lee and White Outpatient Center. I did that because my clinic was on the 8th floor of Grady, downtown. And I really got tired of having to go to the parking lot and sidewalk to find people. Not because I didn't want to, but because I realized it was eating into the time that we had to figure out what's going on with them. So parking was a challenge. Going into the building and finding the 8th floor amid several elevators was also a challenge. So I spoke to Grady administrators, and they agreed that moving would better serve you. At the Lee and White Center, you park, you walk in, and we're ready to go. So when we moved, we actually lost some of the team. And one of the administrators, Belinda, Miss Belinda Bachman, come on, stand up, Belinda. Say hi. She was dedicated to finding people who were on the staff at Lee and White to learn the roles and to make sure that we could keep delivering a service for you. And I learned a few months ago that Belinda was doing this work even though her father was ill. I didn't know it. She was on call, she was responding to messages, emails, and her father passed, but she was still dedicated to making sure that we were able to provide a critical service because she believes in community and the work that we do. So because I lost team members, my program coordinator, Ms. Pam Barreto, come on Pam, you know what to do. She stepped up and did 2 roles while she was 9 months pregnant. So she did the work of 2 people, and she worked up until the day of her maternity leave where she walked out of the building, left, and had a baby. Literally, and came back a month early. So I appreciate that type of dedication to our community, to our health, to our well-being, making sure that as you get older, you can maintain your beauty, strength, and vitality. At some of our programs, if you've been there, some of our community events, we have medication reviews. And that is done in collaboration with the Mercer University College of Pharmacy, the only college of pharmacy in the metro Atlanta area. Dr. Vivian Liao is here with us today from Mercer. And come on. She has really spearheaded that initiative on Mercer's side because a lot of what we do outside of lifestyle involves medications. And many of the questions that people have are related to medication. So they will sit down and go over every drug one by one, what it does and how they interact, so that you can be safe in what you do. That's important, right? So we're in this place together. We are a community, and let's applaud our success, because in doing so, that's encouraging us to do more to move forward. Right? Overall, to wrap it up, there's a lot on the horizon, and what we learned today is that we should not be afraid to take those small steps, to see it through, because in taking those small steps, we can reap large benefits. And remember, like my guitar, even though it's old and blemished, it has plenty of beauty, strength, and vitality in it. So take care of yourself, honor yourself, because you deserve it. Thank you.